I think anybody out of like PA school, nursing school, medical school, once you get out in the real world, like working, you're not 100% confident.
Hello, everybody. Welcome to eShadowing. Hi, everyone. Sorry that we're a little late. We had some technical difficulties earlier, but thanks so much for tuning in. Hey, guys, you all know I'm Rodalyn, the host of eShadowing, and tonight we have Majerry Philius here with us for the internal medicine session. Yes. Thank you so much, Majerry, for coming on tonight.
You're welcome. It's my pleasure.
Thank you. Alrighty, so we're gonna jump right in. So, Majerry, can you first start off by telling us about your PA journey, why you decided on PA, how long you've been a PA, and your path to PA?
Sure. I'll start with because I think my background might give a little bit of more information on why I chose the PA profession. So I was born in a little town in Haiti. My younger sister, she was diagnosed with autism and epilepsy at a younger age. So that's how I was able to kind of see myself being a provider since, she's I'm 5 years older than her. So that's how I came about wanting to be in the medical profession. However, when I went to undergrad, I started with pre-med. So I did biology as a major, and I also did chemistry for minor, and psychology because I was interested in psych. I don't know, but I was just interested in psych, so I did 2 minors. Bless you.
Thank you.
And I attended Baylor University in Miami, Florida. I did wanted to go to the medical route. I took the MCAT. I didn't do too bad. I got accepted to a overseas medical school, but at the time it wasn't. I did not. That's not what I wanted to do. So I thought, do I really want to do the medical school? So I kind of rethought about what I wanted to do. And I asked myself, maybe I should try something different and see if I really, truly love medicine, since I was kind of second guessing it at that point. So I got married. We moved to Tampa, and Tampa, I did a couple different kind of AmeriCorps jobs. And then after, because it was a different city, trying to get acclimated. And then I landed a job at a child investigation with the sheriff office. So at the time, I did 3 years. There was some, you can say it's hands-on, medical healthcare, because I did a lot of hospital cases, meaning I'll go to the hospital if there's a child abuse or medical neglect type of things. So I had a lot of hours there. And then I started to think maybe I should. It was still something I know it wasn't it for me. But it was kind of weird how I kind of landed to the PA profession, because Barry have a PA cohort, but I wasn't aware of that while I was there. So it was one time I had a OB-GYN appointment, and they asked me, "Oh, do you want to see the nurse practitioner?" And I'm like, "Who's a nurse practitioner?" So I started doing a little bit more research, and kind of landed to the physician assistant, career. So I said, let me do a little bit more research about it. And it was everything that I've taken, all the classes. The only thing I was probably missing was maybe statistics, but I took chemistry, biochemistry, Orgo 1 and 2. Even though those classes were super difficult, but I wasn't really missing a lot. With, being an investigation, medical neglect, I had some hours. So I thought maybe I should just do something else more into the medical profession. So I became a scribe. So I scribed for about 2 hours at Tampa General Hospital. And while I was there, I worked. And I also asked all the PAs and the MDs to shadow. So I had a lot of shadowing hours. So my hours came from being an investigator, like medical neglect, child abuse, and then scribing.
Oh, nice. So how was it scribing in the ED? Did that actually count for like a lot of the schools you applied to? Because some schools are kind of finicky about that.
Right. No, it did with the school I applied. So I applied to most of the school in Florida. I applied to more schools than other people because I just wanted to increase my chances. I applied to Nova, FIU, Barry, some other schools in Atlanta, Emory University, Duke University. I applied to a good amount of schools. But I ended up being, I got accepted to FIU, which was great because, my parents and family are in Miami, Florida. So
nice.
we relocated from Tampa again back to Miami.
Nice. So were you in the first cohort of FIU?
No, I was the second cohort.
Okay, so you weren't with Stephanie and I forgot who else.
Majine?
No, I don't know. Stephanie Sherry.
Oh, actually no. So is it the third? I think I'm the second or third. I don't know. I was not with Stephanie. Stephanie was before me.
Oh, okay, cool. Because I know FIU is fairly new.
Yeah, I think I was the third. Yeah.
Okay, so nice.
She was the second cohort. Yeah.
Okay, nice. For anyone that does not live in Florida, FIU is a well-known school in South Florida. It's in Miami, and they recently opened up a PA program. Like, I think their first cohort was in 2016 or 17 or something. I forgot. 2015. I don't know.
Yeah, it was maybe 14 or 15. It's been. I think we're going like in 5 years.
Yeah, so they're relatively new, but just remember, as I was telling you guys, if it's a well-known school but they have a new program, you should be okay with being comfortable with applying, even though they have the like presumptive accreditation where they're not fully accredited yet because they're still new. But you can
we are now.
Right. Yeah. So you can trust them because they have that reputation already. So it's not like it's a random school applying.
Right, I was comfortable enough to apply to FIU. So.
Right, exactly. Yeah. Exactly. That's awesome. That's great. So, so how was your PA journey like once you got into school, especially it being a new program?
Sure, I felt that they were, new program have their pros and cons. I felt that they wanted us to succeed. It was very difficult. It was difficult for me. I have test anxiety. I would not sleep the night before. So it was a lot of lack of sleep before, any kind of exams. But I felt that they wanted all of us to succeed. So they had a lot of, tutoring and professors were highly involved. If we were kind of lacking something, they would be on top and sending email and calling us, making sure that we are comfortable enough to kind of, pass the classes. I mean, PA overall PA school is difficult. You have to get adjusted and kind of like learn how to study. I was out of school for a pretty long time, so I had to relearn how to study. And studying in PA school and regular, undergrad is very different. Right. Of course, my classmates were super supportive. And you can't really complete PA school or do PA school without having any kind of like support system.
Right, exactly.
So you have to kind of get yourself in a group and, just group studies. You can study alone, but I think group studies was a little bit better for me because I was able to recall like more stuff if, someone would ask me a question. Oh, I remember she said this and kind of question me on this type of topic.
Right.
Yeah. But it's a lot. You have to be determined. You have to have support system in school and at home. So it was difficult. It's not easy at all.
Right. And so you lived at home? Like you were able to live with your parents then since it was in Miami?
Yeah, so we thought about like getting an apartment, but we wanted to save.
That's
we stay
but yeah,
yeah, we
you didn't have to worry about rent.
No, exactly, because when we were in Tampa, we were renting and then we bought our condo and we had to sell the condo and move back to Miami because that's when we got accepted. I got accepted to PA school, but we stayed with my mother-in-law. She's great, so yeah. So we stayed and we're still here until we leave. So we're just making money because you have to save money. You can't really do whatever. You have loans and you have responsibilities and bills.
Yes. So I have a good question. How many healthcare hours did you have before applying?
I think I have well over 1,500 because I did count my as a child investigator. Like I did the hospital cases. I did a lot of hospital cases, so I had a lot of hands-on experience with that. So that counted, and of course, my scribing counted for those specific schools that I'd apply for. So it came from being a child investigator and also my medical scribing.
Okay, nice. Awesome. So let's see. Do you have a plan in place for repaying loans? And if you don't mind answering how much loans you got from going to FIU or maybe just like the tuition at FIU?
Sure. I think FIU was pretty expensive. It was $90,000.
Wow.
Yeah, and I think it's increasing, if I'm not mistaken. I don't know what it is now, but it was like $90,000 a year. But I think the first two cohort were obviously a little bit lower, but our cohort did increase a little bit. I'm not 100% sure. I think it was 90.
Okay. Wow. Yeah, mine. I went to Nova, and mine was just the same, like about 80,000. So
yeah.
Everybody just understand PA school is going to cost you. It's going to cost you sometimes maybe a little over 100,000, especially if you have undergrad loans with that. Right. So just be prepared for that. You're likely going to have to take out loans. It's inevitable.
Right. So, and we were allowed. I think maybe one person worked in our class, and I think it's because he was doing cardiology before, and he had some kind of I don't know. He probably used to do it on the weekend, but not like during the weekdays. Yeah.
Okay.
But none of us work really. Yeah.
So, what was your hardest class in PA school?
What was my hardest class? Oh my God.
And you feel like they were all equally?
Yeah, I think they were. I would say farm, but for some odd reason, like I like farm because I was great at memorizing like the names and interaction and adverse effect. But I think farm was hard, but I liked it in a weird kind of way. Yeah.
That's awesome. Yeah, farm was actually the first and only test I failed. So, but the whole class like pretty much bombed it, and they ended up curving it. So
we all bombed. Like, yeah, that some days
I didn't like ethics. Did you like ethics?
No.
I didn't like ethics. I mean, maybe it's because like the professor didn't really do a great job. It just seems so boring. I mean, I feel like it's either you're ethical or you're not. It's not. I don't know if it's something that can be. I don't know if it's something that can be taught. Like how can you teach someone to have moral?
It has to be innate.
Yeah. Yeah, I mean, I guess you can teach it, but alrighty.
I don't even remember that class until you mentioned it. I was like, oh yeah, we did take ethics. Yeah.
All right, so I have another good question. Did you feel prepared to be a PA out of school once you graduated?
No, I did not feel prepared at all. But I kept all my resources I love using Hippocrates, Up to Date. Those are my two favorite resources. If I have any kind of doubt, which you will, I think anybody out of like PA school, nursing school, medical school, once you get out in the real world, like working, you're not 100% confident. But you just have to build upon like your background, like your foundation, and you have to keep learning. I have my desk here, like this is my little black book. Whatever I can't remember, I just write it down. I have a couple of stuff. Even if I know it, I still just like write it down. Like that's after PA school. And I also have like little pocket medicine just to kind of help me along the way. And then Hippocrates is my favorite. Up to Date is just a little bit more, but Hippocrates like in my phone.
Girl, I use Hippocrates every day. Every day.
Right here. This is what I do.
Yes, guys. Yes. I use, like, you guys, when you get into PA school, I mean, this Hippocrates will probably be the most useful on clinicals, during clinicals, but you can start playing with it, like, even during didactic year. Like, once you get into PA school, Up to Date, Hippocrates, even Medscape. I don't really use Medscape that much, but Hippocrates.
Yeah, and it's super easy. It's a user-friendly
yes, it's so easy to use.
You have the labs and everything, or your medication. If you're not sure of even like when I'm seeing patients now, and I don't want them like any medication interaction, and I would tell them like, give me a second, let me take a look, because there's a lot of adverse reaction and interaction with medication. And then Hippocrates have this tool where you can put all the medications and it will tell you the interactions and what kind of symptoms and side effects that it can cause. So that's pretty cool.
Right. Yes, Hippocrates is my favorite.
Yeah, me too.
Yes. Okay. What do you think is the most difficult part of being a PA or being in the process of becoming a PA? Let's answer the second part, the process of becoming a PA, and then we'll answer the first part later. What was the most difficult part during your pre-PA journey?
Does that include the pants? Yeah. Let's see. The most difficult part. It was definitely not the rotations. I enjoyed like my rotations. And the exams were hard, but not, I mean, I was able to pass all of them. But I think pre-PA, post-PA, maybe the pants.
Okay.
Yeah.
What about like pre-PA, like before you got into PA school?
Oh, before I got into PA school. I don't know. I never really thought about like what was super hard because I had all my courses. I think one thing I would tell like pre-PAs is if you're thinking about the PA profession, maybe not doing hardcore. I felt like I went hard with my biology. I took all the hardest biology courses and all the Orgo 1, Orgo 2, which is they're needed right now. So you have to take in biochemistry, and I just took a lot of classes that were not needed. Yeah, so I think that was kind of like the hard part, just like trying to figure out like where I wanted to be, and then doing like that extra. It was just a lot. I mean, it prepared me because I didn't have to take any like much classes before like I applied, only like statistics, but it was just a lot. I just like I did
right.
Yeah, but which is good and bad at the same time.
Right. Yeah, a lot of students do that. They be like, "Oh, I'm going to take this class, all these classes." I'm like, "Why?" Like, I mean, I'm not the most highest overachiever. I took the bare minimum for PA school.
And
for my schools. But no, it's great that you took those science classes though. But don't overwhelm yourself with all these classes that you're going to take at once. It's going to hurt your GPA. Like, don't overwhelm yourself and try to be like a super, super duper overachiever.
Right.
And
Even if you're going to medical school, a lot of people like just take what is needed and then you take other courses. The thing that classes will help you, for whatever test.
And I think it also helps to just take other non-science classes just to, appear more well-rounded. So that's what that's what I did. A lot of my classes were also like non-science. So I mean, I wasn't a non-science major as well. So
like if I would go back, I would not do a minor in chemistry. I would probably just do a minor in psychology and that's it.
Awesome. Alrighty, so we're gonna move on to you post PA school. Was internal medicine your first job?
So the thing is, like, when I graduated, December 2019, and then by the time passing the PANS, with the whole COVID, so it was really difficult to find something.
Okay.
It was really difficult to find anything. So what I did was there's a friend of the family who has a family medicine private practice. So I called them. I said, look, I'm not finding anything. Miami, I don't know it was really hard to find anything. I'm not sure why. I applied to tons of positions. So I called them. I told them, look, I'm willing to come in for free. I'm not seeing you anymore. I don't know what happened.
Oh, it's okay. It says my connection is low. It does that sometimes. As long as I can hear you, that's okay. It'll come back on.
Okay, no problem. So, I called him. I told him, look, I would come in and see patients, and for free. I just want to start working, just to start having some kind of history.
Right.
So I did that for a couple of months, and then things got better, and then that's when I started my my current position right now. With a well-known internal medicine physician. She's been practicing for over 20 years.
So you're in Miami right now?
Yeah, I'm in Miami right now. We're actually right across Jackson North.
Okay.
So we see a lot of patients, from Jackson. So our patient kind of range from very complicated to just primary care, pre-op type of, visits.
Right. So, do you ever go to do rounds at the hospital, or are you strictly office?
Strictly outpatient. She used to in the past, and I did ask her that during my interview, but she kind of stopped and then preferred to do more outpatient.
Okay. Nice. And you've been working there how long?
I've been there since November.
Okay, wow, almost a year now.
Yeah, I've been there since November. She's great, but it's just we need a team. It's hard getting a team together because internal medicine is a lot,
right?
So you can't really do it without a good team.
Right, exactly. So, what does your team consist of?
Right now, my team consists of just a medical assistant because I'm the only PA.
Okay.
So she's not attending, and I'm the only PA here. So there's a referral specialist.
Okay.
And we used to have a couple of medical assistants, but they're no longer here. So it's just the medical assistant, and we do have 2 students. One of them just started. He's a pre-PA. And another one, I think she's a pre-nursing.
Oh, so you said you have 2 students that are shadowing?
No, not shadowing. They're just kind of working, taking vitals and get their hours.
Oh, okay, nice. Do you accept shadows? Are you accepting shadows at the moment?
I don't know if she is. Maybe if I asked her, I don't think she would have a problem with that. But
okay,
we haven't had any shadowing.
Okay, I know it's you probably have it, and a lot of offices have it due to COVID. But I always be trying to help my students and put them on.
No, yeah, I'm sure. No, if I was gonna be here for a long term, like I probably would start doing physical.
Oh yeah,
definitely. Yeah, I don't think she would have a problem with that. I think she would be fine with that.
Oh yeah, okay, yeah. We'll discuss that later.
Okay,
but, for anyone in Miami, we'll figure it out later. We'll discuss that later.
Yeah, of course.
Alrighty. So, can you tell us about like a day in the life of an internal medicine PA, or just your day in the life from when you clock in to clock out, the type of patients you see, the patient population, the conditions that you see, what you typically treat?
Mm-hmm. So my days start about like 8 in the morning. I come in, I review all my notes. I review all, the calls that I have to make, and some labs from like the previous like patients that I've seen before. So I go over my labs and notes and things. And then patients start coming. Our patients are really early. So we see about like 90% like African American, like Black patients.
Okay.
So our patients are really nice. But they come in early, they're ready, and the medical assistant kind of do the vitals and, put them in the room. If you want, I can give you a little tour of like.
Our video's not working. I may have to.
Oh, you can't see me either.
Okay. As soon as it starts working, then we can get a tour.
Okay. And so there's like 5 rooms, so they put the patients in, and then I review, of course, before I go in the room, I review what, why they're here and their chief complaint and their past medical history. If I've seen them before and I kind of have I know why they're here and their information and their past medical history, what medication they're on. So it's a little bit easier when I have that rapport with the patient before, but if it's a new patient, I like to kind of review everything.
Okay.
We'll go under their administration, making sure that they don't have any kind of new ultrasounds, results, mammograms, CT scans, any kind of imagings, any new labs that I have to review with them. Any if they're here for hospital, we have a lot of, because we're right next to Jackson, so we do have a lot of hospital discharge.
Okay.
Patient with chronic disease that come in just to kind of maintain their care. So when we get them from hospital discharge, they come in, we kind of review everything. We get the information from the hospital, all the records. So we have to kind of review, because sometimes when patient in the hospital, they're not aware of what's going on. There's a lot going on. So sometimes they don't even really know what medication they should be on, and who should they be following up with. So when they come, we do kind of help them and get all that information and we do everything with them. We get a lot of pre-op patients that has to go into surgery. So we do a lot of pre-op. We do a lot of primary care.
Right.
A lot of patients with heart failure, respiratory issues, a lot of hypertension. So we have internal medicine include everything. So there's a lot. I don't know if you remember, during PA school, internal medicine was a lot.
Yeah, it was.
Yeah,
it really was. It was everything.
It's everything combined.
All chronic conditions, and then having to refer them and get specialists and. Yeah.
So this is, it's what it looks like in every day when I come in. I just, like I said, do labs and calls, and I start seeing patients. I see about maybe 15 to 20 patients a day. And then trying to do my notes in between, which can be very difficult because some of the patients are very difficult and complicated.
Yeah.
So it's hard to get your note done in between seeing a lot of patients.
Right. So what are your hours, since you see 15 to 20 patients a day? What are your hours like?
From 8, sometimes I leave here around 7.
Oh, wow. Okay. And
Yeah.
you guys, if you didn't know, well, I'm sure you know now since she was talking about a tour, but she's at work right now. So thank you so much, Majerry, for staying a little later for us.
Oh, no, you're fine. Because that's around like, not that late, but I would leave around 7. Like if I have, the energy to, because sometimes I don't. I'm really tired after, you've seen a lot of patients. But yeah, this is around the time, like 7 o'clock, I would just leave. I like to stay by myself and just do my notes.
Right. And how long does it take you to do notes?
It depends. That's one of the most, I would say, like, part of the job that I don't enjoy.
Right.
I thought I would enjoy it as a scribe. Like, I love documenting, because as a child investigator, like, it was a lot of documentation. You had to present the cases to the judge. So it was like kind of similar to like being like you have to go in into the patient and present, your patients you're attending like during rotations. So I had a lot of like, experience with that, but like documenting can be really tasking, but it has to be done. That's the only way you'll be able to get paid. So
exactly.
It's like a love and hate relationship with documenting.
Oh yeah. Someone actually asked earlier what you don't like about being a PA. Is that one thing you would say that you don't like about the profession? I mean, but that comes with just healthcare in general. Whatever you do, you're gonna have to document, because it's CYA and you're seeing patients no matter what you do. So, but what would you say you don't like about the PA career, or is there anything that you don't like?
What I don't like. I think maybe the lack of education that patient has about like our profession.
Right.
I think I'm able to deal with my attending. She's been practicing for 20 years, so her patients are really attached to the hip.
Right.
Her. So coming in, it was, I knew it was going to be difficult, but like, I think I have the personality where I can go in and kind of diffuse the whole, like the wall that they have. I know how to get in. So I think that's one thing that I benefit from is even when I walk in and, I'm not seeing Dr. P. And I'm like, no, you're seeing me. Like, how you doing? How's your day? Like, did you sleep well? Like, you have to kind of diffuse the whole, like, I'm not seeing her today. No, you're seeing me. So you have to know how to walk in and with a positive attitude. You just introduce, hi, my name is Majerry. I'm the PA. I'll be seeing you today. What? No. Where's Dr. P? I'm like, no, Dr. P is here. You'll be seeing me. It's fine. You can talk to me. I'm just here to kind of like go over everything. So how's your day? Just like change the subject. Don't, stay on, Dr. P is, just kind of change it. Like, how are you? How are you feeling? Are you doing well? Like, did you have a good night's sleep? Kind of change the subject. I think that's the only thing. But I think after they see me and I kind of explain to them like what a PA is, I try to educate my patients with obviously their chronic conditions, but also about our professions.
Right.
Because after I do it, it's like, am I going to see the PA today? Everything kind of changed.
That's awesome. Yeah. So a student wanted to know, how do you describe what a PA is to a new patient or someone that's not familiar with the profession, or someone that's been working with your attending or that's been your attending patient for years and now working with you? And
so the way I explain it, I tell them, obviously we're a physician assistant. However, the assistant part is a little bit tricky, as we know. It's not like we're assisting her with like typing her notes,
right.
Kind of thing. We're seeing our own patients. I tell them, like, we went to school, our curriculum, it's like going to medical school, but kind of booked into like 2.5 years. It's different because I tell them like the MD, they do residency. However, PAs now, we do have our residency programs. We do have a lot of knowledge about your, chronic conditions.
Right.
We are well capable of taking care of you. we are educated, so we're just here for the best, to provide the best care as possible for you.
Right.
But I kind of explained to them, like, you know, we have a master's degree, but we are healthcare professionals. We're able to see our patients, and we're able to prescribe, diagnose, and do, you know, a lot of different things.
Right. Sorry, just answering a question. Awesome. Okay, that's a great explanation, though. And somebody else had another question. How independent are you? Are patients funneled in any way? Like, who can see the doctor? Who sees you? Like, before we answer that, actually, how long did it take you to like really acclimate and get comfortable? And how was it when you first started? Were you like working like presenting every patient to her, and now you're kind of more independent and on your own? Or how are the dynamics when you first started compared to now?
So I think I did maybe a month of like shadowing her, kind of seeing like how her day-to-day is like, you know, seeing the patient interact. She would introduce me to the patients a lot. You know, this will be the PA working here, and you'll be seeing her. So she introduced me to a lot of the patients, which was amazing, because I felt like when it was time for me to see, it was a less, you know, hectic to kind of like explain, like, who am I? Like, what are you doing here?
Right.
So she introduced me, but I think I don't know. I'm like, kind of like, I was so eager to start, and she felt comfortable for me to, you know, to go in and start seeing patients like after like a month by myself. But of course, like if the patients, because internal medicine patients can be very difficult, if like, I needed her help, her door was always open for me to go. At first, you know, the first month I would, you know, kind of present the cases to her, but after, if it was, you know, an easy patient or, you know, a patient that I was able to handle and I felt comfortable enough, I didn't have to present every single patient. But now if the patient is very difficult, like I will go in and ask her some questions, and she would just answer the question. Now I'll go back into the room and kind of like explain things to the patients. So I don't present every single cases to her.
Okay, that's awesome. So you said you used to, well, when you first started, you kind of did, but now you're pretty much on your own.
Right. She felt comfortable because I was kind of eager. I mean, I was really good when I first started. So she felt comfortable. She said, I think you're ready. Because it was supposed to be like a 3 months shadowing. And after like a month, she said, I think you're ready. And
awesome. Yeah. Awesome. That's good. You said after a month. That's awesome.
Yeah.
Alrighty. So I'm glad you're seeing patients more independently. So are there any patients that she just kind of specifically handles or sees?
At first, I was like, oh my God, I think she should, you know, get the heart patients. But no, she would let me go in and do like the most complicated patients. And that's how I was able to learn.
Right. I was going to say that. That's
right. No, she doesn't separate like you know, the easy, medium, like difficult patient. No, it was like this patient just came from, you know, Jackson North and heart failure, like respiratory problem. Like you go in and, you know, kind of like work, you know, just talk to them and get all the information. And of course I'll go in and talk to her, and we kind of go over the cases. But she didn't separate like the hard patients from the easy patients for me.
Right. Okay.
That's how you learn. You know?
Exactly.
If you don't want to, like, that's how you learn.
Right. Somebody said, what do you mean by the hardest? I'm guessing like patients with a lot of comorbidities, patients that were probably recently hospitalized, patients with like that were like in critical care and came out the hospital, like patients that, you know, probably have like really complicated or uncontrolled, you know, diabetes, heart failure.
Those are the most
fraction of
15%. Right. So most of our most complicated patients are hospital discharge patients who were just like diagnosed with heart failure or you know, something chronic.
Okay. Awesome. Thank you. So it is 7:52, guys. Okay, so we're gonna go on we're gonna do the tour, and then we're gonna we're going to do the case study. So let me try refreshing my page to see if I can, because I want to see the tour too. Everybody's saying that their video is working. My internet is not the greatest where I live. So my video, I can't see you, but I want to see the tour. So I'm going to try to refresh my page.
Okay, so you can see. All right.
All right, guys, give me a second. And FYI, whenever I refresh the chat feed, I lose all the chat questions. So if you have if there's a question that I did not answer, you can ask me again, or you can just email or DM me. It's probably best to email or DM me because I try to like filter through the questions and ask more relevant questions. So if it's something personal, just email or DM me. All right, let me just refresh. Okay, there we go. All right, yes.
Hi, you're back.
Alrighty, I see. I know. Awesome. So I'm ready to. We're ready for this office tour.
All right, so I'm currently in my room, in my office. Let me like stand. I think I'll have to like bring my laptop with me. So this is like where I keep like all my little documents and files. This is my computer. I also use my laptop so I can like, when I'm doing charts, I do like 2 charts at once. All right. So this is like the lobby where all the patients come in.
Okay.
Can you guys see? I think you can.
Yeah. I mean, I see. I hope you guys see.
And this is like the room 1. Where patient will come in and they sit, and this is my computer. I would just, go in and log into their, their charts and everything. And then what's cool about this is this. I don't know if it's working. I do love educating patients. I think it's like one of the most important things that you should do as a provider.
Yeah.
So this kind of give me the tool. I don't know if you can see. It has like different kind of like anatomy condition that you can explain to patients. So I like to use like when patients are like refusing to do their colonoscopy. So I kind of like educate them like, what a colonoscopy consists of. So just kind of show them like the picture. It's loading right now. Just kind of give them an image. Can you see?
Yeah.
Like,
yeah, we see.
Of like, exactly what's happening like during your colonoscopy. So they like when I do this, I kind of educate them. There's different like artery blockage that I like to kind of like explain to them, like the percentage of blockage, and 20% that's how it looks like, 40 and completely blocked. So
give me 1 second. You can continue the tour. Give me one second.
No problem. And this is where our medical assistant, referral specialist, the front office. This is another room. This is the second room. So all 5 rooms are sometime have patients in. And this is the 5th room. I don't know if you can see. It's a pretty big room. And then we have where the patient comes in and do different kind of tests or lab tests or H. pylori and things like that. I don't know if you guys can see.
How many rooms are there?
We have 5 rooms.
Okay.
Yeah. So I'm just like closing all the lights and so I can go back. All right, so that was it. It's a pretty small office. So but
that's really cool. That's really nice, and I'm sure you like build like really strong relationships with your coworkers.
Yeah, of course. Yeah, we do. It's pretty like just tight,
Awesome. Thank you so much for that tour. It was a really nice office. So we're gonna jump right into the case study, guys. I know that it's almost 8 o'clock. If you have to go, of course you can go. We did start a little later, so we're gonna go past 8 o'clock. A few minutes past 8. So, but if you can, stay on and go through the case study, that'll be great. So, Majerry, if you want to pull up the case study, you can, if you go under files, if you go under slides, you can click on add a new presentation. It should be all the way at the bottom, or you can share your screen, whatever you want to do.
I think I'll share my screen. Okay. So it would turn screen share on, right?
Yes. If you at the top there's a little button that says turn screen share on with the computer monitor.
Okay, let's see. This case was more of like a GI specialist type of case, but I feel like it's a case where patient would probably go to the ER, or if they have an insurance that they can go directly to see a GI specialist. So when this patient came in the office, I thought it was a pretty cool case to kind of go over. So it is part of the inflammatory bowel disease. So I kind of put a question mark because I just want you guys to kind of like interact and kind of guess like which one that I will be presenting. All right, so let's start with the HPI. So I had this really nice patient come in. He was a 33 African-American male. He has a history of anemia that he was diagnosed a couple of years ago. So he came in the clinic basically kind of complaining about this crampy abdominal pain that he had. He kind of rated like 5 out of 10. He also was complaining of this non-bloody diarrhea that he's been having on and off, and some weight loss, which was very concerning to him. What made this case a little tricky, he did mention that so he had a dinner date with his wife, and then he had some sushi. So after the whole sushi dinner, he started experiencing those symptoms. So maybe, we were thinking maybe, it was stemming from that, but because it's been happening for like 3 months, I don't think it was a case of like gastroenteritis. It was more than that. So, as we were talking, he kind of mentioned this abdominal pain, like and diarrhea slightly subsided after he took some Pepto-Bismol. But what was really concerning to him was the weight loss that he was having, which is something that he wasn't trying to lose any weight. So he was not evaluated by anybody, no urgent care or ER. This was actually his initial encounter for the symptoms that he was having. So he denied any sweat, any bloody stool, no fever, nausea, vomiting. So his past medical history was anemia and aphthous ulcers, which is like a canker sore that normally you get in your tongue. It's really irritating. I get them sometimes. They just come and go. Yeah. He had a family history of hypertension and pancreatic cancer. Social history, he's an attorney. He lives with his spouse. Occasional like alcohol use, but nothing serious, and he denied any substance abuse. So with review system, it kind of broken down. I didn't put everything in, just like the main one. Constitutional was obviously the weight loss that he was having. He didn't have any fever, chills, fatigue, or any weakness. And then when it comes to the HENT, he had the canker sore, but no sore throat or blurry vision, eye pain, or eye redness or anything. For the GI symptoms, obviously he had the crampy abdominal pain that he was complaining of, and diarrhea, which is non-bloody. And he also has a history of like joint pain, something that just comes and goes, but nothing too serious. Vital signs were pretty normal. Heart rate was 85, blood pressure 118 over 77. So vital signs were pretty normal. Nothing that was too concerning. Temperature was fine. Pain level, which is PL, was like 5 out of 10 with the abdominal pain that he was having. During physical exam was pretty normal. The only thing that he was having was when I touched his stomach and auscultate and palpate, he had a little bit of tenderness on his right lower quadrant his abdomen region. But he has no CVA tenderness. Everything was normal. just a little bit of tenderness on the right lower quadrant. So physical exam was, sort of normal. So with all the information that I've provided, can some of you guys give me some of the differential diagnoses you're thinking of with the crampy abdominal pain, the weight loss, non-bloody diarrhea? What are some of the differential diagnoses are you thinking?
So some people already started to put some. I saw diverticulitis, colitis.
Okay, yes.
Diverticulitis.
Mm-hmm. That's pretty good. Okay, so I'm just gonna start with the differential diagnosis based on what he presented with. The first thing we're thinking is Crohn's disease. Is this Crohn's disease? We're not sure. We have to do some more investigation and trying to figure it out. Ulcerative colitis, it might be. Again, we have to do more testing and trying to figure out like exactly what's going on. Irritable bowel syndrome, which is very common, and a lot of people get irritable bowel syndrome confused with inflammatory bowel disease. Those are completely two different diseases. They sound like IBS, IBD, but they're very different. Colorectal cancer. With his age, I'm not sure. I'm not 100% sure. However, you never know. Since colorectal cancer has become more prevalent in younger patients. As we all know, Chad from Black Panther passed away at the age of 40-something years old from colorectal cancer. Appendicitis. Yeah, I maybe not sure. During physical exam, he did have right lower quadrant pain, tenderness, but we still have to do more investigation and trying to figure it out. Or celiac disease might be. We don't know. All right, so those are some of the differential diagnoses that I came up with, during the time that I was seeing him, and I was kind of going over in my head and a couple of stuff that might be happening. All right, some of the assessment and plans that we did, we ordered some blood work, CBC, just to make sure he's not anemic. He does have a history of anemia, so we just wanted to make sure his hemoglobin, white cells counts, CMP, just to make sure he doesn't have any kind of metabolic disturbance, since he is having a lot of diarrhea. I wanted to check the UA urine culture, iron studies, CRP and ESR, just to see if there's any kind of marking for inflammation. ASCA and P-INCA, those two autoantibodies are not commonly used, but I just put it there just to if you are a pre-PA, pre-nursing, pre-med, you will have a lot of different autoantibodies that you will have to remember during any school. So I just put them there for you to just remember. ASCA is mainly associated with Crohn's disease, and P-INCA, ulcerative colitis, but they're not definitive. And ordering CT of the abdomen to see exactly what's going on, and obviously referring him to GI specialists to do more testing and of course colonoscopy. He did complain of this joint pain, so we refer him to rheumatology and of course dietitian, just to see exactly kind of help him with his his lifestyle modification. I put gold standard definitive diagnosis because I think we're kind of leaning more towards Crohn's disease. And this is the only way you can be 100% sure that the patient has either ulcerative colitis or Crohn's disease.
Right. Somebody said, what about stool studies?
Stool studies, yes, you can, but at the time we did not.
Okay.
Yeah, we did not do, because I think we were pretty sure that he had, Crohn's disease. So these are some of the things that we felt it was the best for us to kind of start with. And then, of course, the treatment plan was first to kind of talk to him about his lifestyle modification. So start like logging his food that kind of worsened his symptoms, exercising, refraining from any smoking, because that can worsen your Crohn's disease. Mm-hmm. And of course, like avoiding any type of NSAIDs. To start, because he was having the flaring, so we started him on prednisone, which is the lowest dose, and then trying to like taper it. But at the same time, we did refer him to GI for if he's having any, or if he was. I mean, with Crohn's disease, it's kind of like a lifelong disease, so you have to have a GI specialist to monitor your symptoms and kind of, change your medication, taper your steroids, or start like different kind of medications. So we did do the refer to GI for that. So let's talk a little bit about inflammatory bowel disease. So there's two different kinds, which is what we already know, Crohn's disease and ulcerative colitis. So these are some of the common things that you can find with both, with Crohn's disease and ulcerative colitis. So basically, they are idiopathic. We're not 100% sure what caused Crohn's disease. There is some genetic aspects or environmental aspects of it, but not 100% sure. So basically, they are like an inflammatory autoimmune disease process that involve the GI tract. The age of like onset for that, it's between like 20s and 30s. My patient was 33, so he kind of fell into the age of onset. And higher incidence are found in Caucasian, I don't know if it's Caucasian patients and Jew patients. So it was, very interesting to see that this patient, African-American patient that came in, and he was suffering from Crohn's disease. Increasing incident and higher incidence in developed countries. And of course, it increased the risk of colon cancer, as well as reducing quality of life from all the symptoms that they will be experiencing. And increasing colon cancer, which is the main reason why we have to refer to a GI specialist. So this kind of what would you say, like a not separation, but like this kind of give you like a visualization of the difference between Crohn's disease and ulcerative colitis.
Right.
It's like, just like a simple table I got from Roche Review. Be familiar with Roche Review, because during PA school, that was one of my favorite tools to study, and the questions are amazing. So they do have a lot of. Do you know about Roche Review?
Yeah, I've heard. I actually didn't do that in PA school, but I was in PA school a long time ago. So
okay. So yeah, they're really common now. A lot of
I've heard.
PA school, yeah. So they do have like amazing pictures and tables and graphs and things. So this is from like Roche Review. So it kind of show you the differences between Crohn's disease and ulcerative colitis. So for Crohn's, you have your chronic diarrhea, which my patient had, the crampy abdominal pain. He didn't have any fever, but he did have the weight loss. Not really fatigues. And for ulcerative colitis, it's almost like the same things. The difference is the tenesmus, which is like the cramping of the anal region. And they do have the fecal urgency. And they have the chronic bloody diarrhea, which is, similar to Crohn's disease. And the difference between Crohn's disease, also, they do have the fistulization, which is a fistula that can cause a lot of recurrent UTI, which is the reason why I did order a UA and a urine culture on my patient. But he wasn't complaining of any like anal pain or anything. So the GI tract involvement for Crohn's disease is more like the transmucosal inflammation. So basically, it's kind of infecting the whole layer of the GI tract, which is your mucosa, submucosa, muscularis, and the serosa part of your intestine. So all 4 layers. And you have to remember there's during any kind of imaging, you'll see something called skip lesions. These are all like little words that you have to remember during like PA school. So you can differentiate between like Crohn's disease and ulcerative colitis.
Yep.
And for the GI tract with Crohn's disease, it affects any part of the GI tract, meaning from like the mouth all the way down to the anal area.
Yep.
And for ulcerative colitis, a little bit different. So you have the mucosal inflammation. So you have a lot of inflammation. There's no skip lesions. And the rectum is always involved for ulcerative colitis. And then you have the GI bleeding, positive, but ulcerative colitis is more like grossly bloody stool that you will see it. You can actually see the blood in the stool. And there's something that's it's called like extraintestinal manifestation. If you get the extraintestinal, meaning that anything that those symptoms or those condition are not part of the intestine. So it's more like in the outside portion of your body. So with Crohn's disease and ulcerative colitis, they do have like the same things, the uveitis, which is the inflammation of the sclera. And then you have the erythema nodosum, which is kind of like, they're like bruises in the shin area of your lower extremities.
Right.
They can be painful, but not. But when I did see my patient, I did do like a thorough like physical exam on him. And there's other stuff like arthritis, which was, another thing that I was leading towards because he was having a lot of joint pain.
Mm. Right.
Let's see. So this is kind of like you can see it better, like what I was describing before. So you see your Crohn's disease here. You have the skip lesions. You have the cobblestoning on endoscopy, the transmural inflammations, and this is what we already talked about. And then, of course, the ulcerative colitis, and then show how it's more focused on the large colon. So just take a look at what a colonoscopy looks like. I think the first picture, it's like it looks like triangular. I think it's maybe transverse colon. And then the middle, it's your see all the polyps or your skip lesions. That's the signs that you will see during colonoscopy for Crohn's disease. You see the inflammation. And then the last picture is it's ulcerative colitis. You can see the difference between the Crohn's disease and ulcerative colitis. Ulcerative colitis have this inflammation, but no like polyps or any skip lesions. So I have the first question for you guys. After all, like I already went through. So what do you think about question number 1?
My video shut off again, so I'm not able to see the first question.
Okay, that's fine. Skip lesions of color of epithelioid granuloma are usually seen with
what condition, guys?
Is it A? Is it irritable bowel syndrome? Is it ulcerative colitis? Is it
Crohn's? C. I see everybody said C.
C. Nice. Yes, it is C. Like we just talked about, the skip lesions that we saw on the picture here. See, it's all like over the colon and the small intestine, so it skips everywhere and it involves everything. Compared to ulcerative colitis, it kind of focuses on the big colon. All right, so next question. Toxic megacola is most commonly associated with, is it Whipple disease, Reiter's disease, ulcerative colitis, or Crohn's disease? What are you guys thinking? No question, no answer?
I see C.
Right. Okay. So that's good. Toxic megacola is most. These are all like questions. They're really easy questions, but if you start to kind of be familiar with the, with different like diseases like toxic megacola, basically meaning there's like inflammation. It's like a complication of ulcerative colitis. For that, you would definitely need surgery. Okay. So it is ulcerative colitis. And in the last questions, I did mention that before. Fistula is most commonly associated with is it celiac disease, ulcerative colitis, infective enterocolitis, or Crohn's disease. What are you guys thinking? Any answers?
I see D-A-D-D or A-D-D-D-D-D. Everybody's saying D-D-D-D.
That's right. Like I mentioned before, fistula it's like a complication of Crohn's disease. Like it's not common, but you can see it in patients that have like Crohn's disease. And fistula is basically like you can see it in the anal area. It's like a little hole, a little connection forming from like the colon into the anal area. So a lot of times bacteria can go out in that area, which can cause infection, and you have to place the patient on like antibiotics. And that's it.
Thank you so much, Majerry. That was a really informative. Your PowerPoint looked really, really nice. Before my video cut off, it looked so. I loved your charts. Like it looks so pretty. Like you took a lot of time on it. Thank you so much.
You're welcome. I'm trying to like get out.
And thank you for the questions. Those questions were were very helpful.
Yeah, sure. They're really easy question, I guess, for us, but always it's never too early to kind of, yeah.
Thank you so much. And yeah, that was very informative. And those questions that she asked, guys, they are common test questions in PA school and on the pants, okay, about Crohn's, ulcerative colitis, inflammatory bowel disease, everything she went through. She made some really good key points. Awesome job, Jerry.
You're welcome. I hope you guys enjoyed everything.
Thank you. So you guys, thank you so much again. I'm sorry. I know we went past 8 o'clock. I actually have to be at work in 10 minutes, so I have to cut.
Oh my gosh.
Don't worry, I live like 5 minutes from my job.
Okay, good.
I'm about to call my Uber. Majerry, is it okay if I attach your Instagram or any way to reach you in the chat?
Yeah, sure. You could just put my it's Majerry PAP.
Okay. This is her Instagram, guys. If you guys have any questions for her, and then I'll put mine too. All right. Thank you, guys. Thank you so much once again, Majerry. I love this session. This was awesome.
You're welcome. It was my pleasure.
Thank you. All right, guys. So we're going to end the session. Have a really, really great night. Once again, feel free to email. Oh, let me put my email too if you guys need to email me or DM me on social media. Hope you all have a great week. All righty. So I'll see you guys later.
Bye.
Next Monday. Bye. Thank you. But you can end the session by pressing that red button.
Okay.
Thank you. Bye, guys.
You're welcome. Bye.
Bye.